Mr. Puijk, please.
Thank you, Julius, and thanks to the organizers for having me telling something about the AMCORE registry, which is the Amsterdam colorectal liver metastasis registry, and the final results of the COLISION trial, a phase 3 RCT comparing surgery versus thermal ablation. So looking at the current status for local treatment options, if you have a look at the NCCN guidelines, so this is the version of 2022, they state that hepatic resection is still the treatment of choice for resectable disease, and ablative techniques may only be considered for as an alternative or as a conjunction with resection. The recent revised ESMO guidelines, they placed radiofrequency ablation next to surgical resection and SBRT as a valid local ablation treatment option. So to date, these two studies, so of which one comes from our database, the AMCORE database, are the largest studies to date, reporting overall survival. And our study, which is a 10-year analysis, reports an overall survival after ablation alone. And that result, so that overall survival curve, looks quite similar to the one after surgery from the Memorial Sloan Hospital. And also interesting to see is that there's something like a plateau phase after 10 years, which suggests that both ablation and surgical resection is a curative intent treatment option. So this data is coming from our meta-analysis published several years ago. You see that, well, it's kind of a no-brainer. After RFA, the complications are less compared to surgery. But if you see the overall survival, it's still slightly in favor of surgery alone. Although I have to say that these studies were mostly from 20 to 15 years ago. So if you look to the last published studies, which I will show you on the next slide as well, there's a historical trend towards equal outcomes regarding overall survival. And for ablation, so in this series, only unresectable disease got ablated. So there's a high risk of residual bias in there. These are the latest reports, so from 10 years ago until today. And I do want to highlight the Maverick trial, but you can see that in all these series, the overall survival curves are overlapping, comparing resection and ablation, or ablation plus resection versus resection. So the Maverick trial, it's published last year. It's the first comparative trial from Sweden and the Netherlands, but it's not randomized. So what they did was treating patients with stereotactic microwave ablation, and they compared them to a control group from the Swedish liver database, and they also looked at overall survival. You can see once again that the overall survival curves are overlapping between the two cohorts. This is also data from our AMCORE registry, so from the 10-year analysis. We divided all the data into three different subgroups, so dividing them into different timelines. And you can see these are the curves for local tumor progression-free survival. After open ablation, there was a significant improvement in LTPFS, but more importantly, there was a great significant improvement after percutaneous ablation over the last 10 years. So we came from like 50 to 60% LTP rates to less than 10 in the last cohort. And that is mainly to do in our center, for example, with image guidance. So what we do during each procedure is placing a catheter in the common hepatic artery, and we, by giving small amounts of contrast before, during, and after the procedure, you can better visualize the tumor, but also the ablation zone. So it helps you to navigate, to get your safety margins, and last but not least, it helps you with image fusion and registration and confirmation. What also helped improving the LTPFS over the last decade was the change in our hospital in clinical day practice of midazolam sedation to propofol sedation and general anesthesia. And you can see that by using propofol or general anesthesia, the LTPFS also significantly improved. Patients got less pain during the CT-guided procedure, less movements of the patients, better control of breathing, of course, with a breath hold possibility as well, leading to more precise needle placements and lower LTP rates. So the question, like 8 to 10 years ago, was, do we need a randomized controlled trial? If you look to the mortality rates, complication rates, hospital stay, etc., you can see, if you look at the literature, that there is a difference between surgical resection and ablation. So that's why we set up the trial. But also, if you look, and this is the data from the Dutch Institute for Clinical Auditing, who are registering all the resections and ablations in the Netherlands, you can see that still now the majority of disease is still being resected. Also, if you look, and it's also interesting, to the low volume centers, they still favor resection, but the high volume centers already favor ablation. But still the majority is being resected. Some other attempts, this was the LAVA attempt from the United Kingdom and the Netherlands. They only focused on patients with high surgical risk, but unfortunately they failed to recruit an adequate number of patients, so this one stopped early. There's another attempt from Oslo in Norway, kind of similar design as the COLISION trial. The only difference is the primary outcome, and for the new COMET trial, that's local tumor progression after 1 year. That study is still ongoing. So our research question was, should we favor ablation or surgical resection for small size, so smaller than 3 centimeters, liver-only colorectal liver metastases? I think you might know the trial design. So maximum number of 10 lesions, the target lesions, so they have to be resectable and ablatable, maximum of 3 centimeters. And we divided them into stratification arms, so low disease burden, intermediate and high disease burden. I want to show you some examples of the limited disease burden, for example, and the other ones, because there are always questions, do you randomize lesions or do you randomize patients? And we only randomized patients, so not the lesions. And for example, this is a low disease burden group where you have 3 target lesions, so both resectable and ablatable. If randomized to resection, then all the lesions got resected, and randomized for ablation, all the lesions got ablated. It's getting more complicated if you look to the intermediate or high disease burden group. So again, we randomize patients. This yellow one is a larger lesion, so larger than 3 cm. That one needs to be resected anyway. So if randomized to resection, everything is being resected, and if randomized to ablation, the larger one is being resected, and all the other lesions are being ablated. And of course, they were all reviewed by an expert panel of all surgeons and interventional radiologists involved. The study was running in more than 13 centers in the Netherlands, 2 in Belgium and 1 in Italy. This is the statistical analysis plan, and this one is the half-time interim analysis. And I'm going to show you this one because we stopped at half-time. So our predefined stopping rules at half-time, they now do matter. So we included 50% of the sample size, and we performed this analysis 12 months after having included the last patient. Stopping rules for benefit were a low number of adverse events in the ablation arm, no significant difference or superiority regarding local control in the ablation arm, and a conditional probability to prove the primary endpoint, which was to prove non-inferiority of overall survival for the ablation arm, and that conditional probability needed to be over 90%. Some baseline characteristics, and I do want to highlight this subgroup analysis. If you look to the low disease burden group, so 1 to 3 lesions smaller than 3 cm, you can see that in 64% of the resection they used robot-assisted resection or laparoscopic resection. And for the percutaneously treated, those were 83% of the ablations in the low disease burden group. And if you compare that data to the, which I showed you before, the Dutch clinical auditing data, so the real-time data in the Netherlands, you can see that in the trial there's a very high percentage of nowadays robotic resection or laparoscopic resection, but that also goes for the percentage of percutaneous ablations in the trial. So it really compares the modern-day surgery to the modern-day ablation techniques. So the primary endpoint, overall survival, we didn't saw any difference between the two study arms. So p-value of 0.83, so no statistical difference, and the conditional probability to eventually prove non-inferiority was 91%. Secondary endpoints, and this was a little expected. So there were more complications, significantly more complications after resection, but also significantly higher grade complications after resection compared to ablation. The length of hospital stay was shorter after ablation, and that had mainly to do with the fact that there were significant more people included in the subgroup A, so the limited disease burden, treated with percutaneous ablation, and they are only admitted in the hospital for one night, but also a significant difference. Distant progression-free survival, those curves were overlapping, so no difference regarding that. The same goes for local tumor progression-free survival. We have to analyze that per patient and per tumor. Also, no statistical difference between the two study arms. Interestingly, to highlight is if we look again to the Dutch clinical auditing data, I have to mention that the R1 rate with 12% is very low in the trial. Also, 5% of the patients who received ablation had an insufficient margin, which is also quite low if you compare that to our national data, but also to the recent literature. So everything in the trial really compares to the current clinical setting worldwide. Looking at local tumor control, so allowing repeat treatments, we also analyzed it per patient and per tumor. You saw a significant difference looking at the per tumor analysis. That is mainly to do with the fact that people who received ablation got retreated more easily than after receiving extensive surgical resection. So again, the subgroup analysis regarding LTPFS and local control, we analyzed or we compared the percutaneous ablations with the laparoscopic and open ablations, and regarding LTPFS and local control, we didn't find any difference. We also compared the percutaneous ablations to robot-assisted or laparoscopic resection. Also no difference in LTPFS or local control. But we saw a significant difference regarding difference per institute. So that was significantly different amongst different centers if you look to the local tumor progression-free survival. And that had mainly to do with the fact that not every center was using the same navigation technique or ablation confirmation software. So in summary, COLISION stopped at half-time based on predefined stopping rules, showing benefit for the experimental arm ablation over the standard of care, surgical resection. So for patients with small-size liver metastases, thermal ablation substantially reduced the morbidity and mortality, and was at least as good as surgical resecting in local controlling the liver metastases. No difference were found in local and distant tumor progression-free survival, and it didn't seem to compromise the overall survival. Of course, a few things to discuss about. Stopping early, well, in this case for ethical reasons, has some disadvantages. For example, for not having reached the sample size, of course. So there's some serious imprecision. If you look to the grade recommendations, then it's only highly likely that it's only being downgraded from very high evidence to high evidence. So there's still high evidence for the primary endpoint. Early benefit, of course, is not the same as having proven the primary endpoint, which is non-inferiority. We can only draw hard conclusions for the entire group and for the limited disease burden group, so not for the more extensive disease. And as I've said, experience matters, such also image guidance matters, of course, and the same goes for ablation confirmation software. So for the future, we are now looking to set up a COLISION 2 trial, which is implementing the best clinical practice, so using navigation, etc., in a stepped wedge cluster trial for the near future. Thank you.